Hello, everyone. It's so nice to see you here on a Tuesday for a new VMR session. Yeah, welcome. As you know, Tuesday is where we get to discuss and learn with Ravi and from a case that I hope some of you or one of you will be presenting today. So I think I want to start by just asking if anybody here in the chat has a case they want to share with us and present today, then please let us know. We would be very happy about that. And in the meantime, I think I'm just gonna go through it's nice to see also some videos. I see Marino and Junia, you have your videos on, and Shal as well. I'm sorry if I pronounce some of the names not the perfect way, but yeah, do you want to share where you're calling from? Maybe Marino, do you want to tell us?
Oh, hello. I come from the Dominican Republic here in the Caribbean. It's actually very hot in here. I used to be a frequent one here in the city solvers like back September last year, but some personal issues happened and I couldn't join you. So now I've been presently like since Thursday, so it's good to be back actually.
So nice to have you back again. So I'm just checking the chat in the meantime. If anybody said, does anybody have a case for today's session?
Yeah, I also want to chime in. Anybody that is here for the first time, I see a lot of new faces, but I want to shout out Chunya I met on Sunday, who's logging in from Japan. So we really have an international crew. How are you doing, Chunya?
Yeah, I'm doing great, but I still got sick and my voice is still hoarse. Pediatric virus is kind of like strong for me, so it takes a couple of weeks to kind of get recovered from that. But I'm doing great. It's so amazing to be here with you. Thank you.
Awesome. It's such a pleasure to have you here again and to be engaged with the CP Solvers community. I see Beatrice is on. How are you, Beatrice? And then welcome, Marino.
But I just arrived in my room in my college. So yeah, I'm just arrived from the airport. I'm super dead, but can't wait to listen to one of the cases here with you.
Awesome. Yeah, I remember you were traveling. We saw those wonderful picture. Hello, Beza is here. Long time no see. How you been, my friend?
Good. Thank you. Just the good news is I have matched in one of the hospital here in Georgia.
Oh, wow. Congratulations.
Thank you.
Congratulations.
That is amazing news. And this is outside the match or this was during the match?
It's just within the match.
Oh, okay. Georgia. Awesome. Which city in Georgia are you going to be at?
Griffin.
All right, awesome. Is that close to, there's either
south,
Atlanta?
Yeah, south to Atlanta, like 50 miles.
Excellent. And have you already moved here to Georgia?
Already I'm in Atlanta.
Excellent. And I see you're getting prepared for intern year by attending CP Solvers. And I can attest to you, just learning how to present here, learning how to discuss cases will carry you a long way. And this investment will pay off because I also deal with a lot of IMGs and they learn through this method how to present in the US kind of system. So great to see you. I see also my good friend Mario is here, who presented a absolutely smashing case of solitary cell plasmacytoma a little while back. I know he's connecting to audio. And still looking, anybody that has a case. Oh, I see Anchal Gupta is here as well, who's joining for the first time. Are you in a safe space to unmute your mic and also introduce yourself if you can?
Hi everyone. Yes, I am Achal. I'm a Caribbean med student and I am actually going to graduate soon, and meanwhile I was doing research at CU.
Awesome, awesome. So yeah, this is also a great time for you to invest some time in learning how to dissect cases and re-engage with clinical medicine while you're doing research. So welcome and lots of luck to you in your future journey into residency.
Thank you.
Yes, we don't have a case. Did you see anybody in the chat, Leah?
I didn't yet.
All right, no problem. And I'm going to make a plug here. We did announce on Twitter I was very nervous presenting my first case long ago. And so it's always natural to have that sort of an instinct. And we can help you if you do want to present a case and you want to, maybe you're not familiar with the format, by all means, reach out. We did announce it on Twitter. Is it via email, Deborah? I don't remember, but we can help you put together a case and then present on CP Solvers. And actually, you can put that on your CV as well. So we have a link to show how to put it on your CV when you apply for medical residency.
Hey everybody, this is Hassan. I saw the Twitter post. I do not have a case to present today, but I'm an attending, so I have plenty of mentees that are going through the preparations to go into residency. So if I can help in any way, I'm more than happy to.
Oh, welcome, Hassan. Great to hear from you. And absolutely, I do actually encourage my students also to present. And I also tell them, hey, you can put this on your CV, and it's an oral presentation. So definitely is part of what we call electronic scholarship. So by all means, bring your students if you can, or if you do want to engage with mentoring students or other viewers to present cases, do chime in and contact us, and we'll be glad to connect you with the team.
Happy to. My students are from Morocco. I am originally from Morocco, but I live in California now, and faculty at the UC system.
Awesome, awesome. Yeah, by all means, mentor those that are back from your home country to now, as we have succeeded, is always good to see others be able to make it and help those that are probably in a less fortunate position. As you know, applying can be very expensive and can be very difficult. So helping to navigate the system will be very helpful. I guess, Deborah, do you have a backup case? I think Leah will tackle it. Again, I am so happy to be discussing with Leah. Leah, longtime CPS member, is just so full of knowledge and has become over the years a very, I would say, an developing expert in clinical reasoning. So I'm always very happy to see what she has to say and learn from her. So this learning is always an ongoing process. So Leah, I'll have you start with the first aliquot that Deborah presents.
Yeah, welcome everyone that is joining us for the first time. I will add to the chat some more information if you want to present a case for us, because we are having like a lot of people of our team helping with that, so we can have everyone here presenting different cases. So I will start with the case. It's a 33-year-old man that presents recurrent episodes of abdominal pain. The patient have like a severe epigastric abdominal pain that occurs about for a month for the last couple of years, like once a month for the last couple of years. He has been told that it was something related for the pancreas, but had no diagnosis. And he presented to the emergency room, received opioids that had some relief, but without that, nothing helped him. So he's concerned about having another episode, and he said that is associated for nausea and vomiting. I think I'll stop here.
Wow, thank you, Deborah, for sharing this first aliquot. It's really interesting to see kind of the history. It's not the first time he's presenting, so it's a recurrent episode of things. And so I'm thinking, how should we start tackling this? This is still a relatively young person, and he has this epigastric pain. So with abdominal pain, always the first approach that can help is is kind of going the anatomic approach. But what I thought, or often I've seen cases of abdominal pain where localization is might be diffuse or wrong in the beginning. So don't just rely on the localization alone. But so here are several informations about the pain. So chief complaint is abdominal pain. We have the patient who's relatively young. I would want to know what kind of person are we dealing with? Does he have past medical history? Is there any risk factor behavior? Because that will be relevant, especially when we think about the pancreas later on as well. So young patient, abdominal pain, epigastric, can think about the localization a bit more there, and then recurrent episodes. So that is interesting because recurrent episodes could make us think of, are there any triggers that might lead to presenting the same thing, or what does recurrence actually mean? Does he go back to baseline in between, or is there always some kind of complaint, but then it gets more severe? So I would want to know more about how have past episodes been for him and what is normal. And then nausea and vomiting, which is relatively unspecific, and I wouldn't focus too much on that just now. But I think when we think of epigastric pain, then of course, pancreas is something we can think about, especially with very severe pain. And for pancreatitis, which would be a differential here, I know Ravi has often talked about make it quite simple. Either it's ingestion or obstruction. So either stones, and that is one of the most common causes, and then alcohol or other toxins or medications. So getting a history on that will be helpful. And yeah, I think epigastric pain, pancreas, maybe some gastric complication, other organs that are close by, the liver, the spleen. But I think imaging and labs will help a lot here. And also knowing what setting we are in is important to kind of know where we should put more weight in our diagnostic reasoning. That would be my first approach here. Ravi, what do you think?
Oh, I just love your thinking there. What you have deployed there is very analytical thinking, keeping it simple. So KISS, and that you're keeping, not investing too much into one probably framework, but just kind of looking over a number of different possibilities. I like the setting. So as we get more information in the next aliquot, maybe the history will give us some clues, like if there's diabetes, maybe could this be diabetic gastroparesis? If there's some pre-existing liver issue, could this be of a hepatological etiology? At this juncture, it's difficult, but I do like what I've loved to sort of thought of, or what I've learned to think about is this something that's catastrophic? Is this something that, if I'm seeing this patient in the emergency room, do I need to call surgery? So start going through life-threatening causes. You sort of did glean over a number of itises. So all the itises could be cholecystitis, hepatitis, pancreatitis, and so on. And then going through maybe vascular causes like mesenteric ischemia, and then going through some possibilities like obstruction or perforation. And that will hinge on the exam. If you have a massively distended abdomen, then you may be dealing with perforation or obstruction. And then also looking at the labs for any hallmarks of something that could be a harbinger of ominous disease. So maybe lactic acidosis. Also looking at the vitals, if there's any hypotension, could also be an indicator of serious disease that could be life-threatening. What really has me bothered, though, this is a young patient, and this is a very common complaint. Then if you see what's in red, epigastric pain, nausea, vomiting, how do we kind of juggle this cognitively at this point? I don't know if the nausea, vomiting is secondary. So I take the nausea, vomiting, and I put it to the back, and I invest all my thought process into the epigastric pain, or are these traveling together? So are these both, like I had mentioned, like maybe like if you have a DK, you can have epigastric pain, you can have nausea, vomiting. So these things could be either simultaneous, or one could be occurring because of the other. So I'm not going to go into too much detail at this point. I don't think it's effective with the amount of time to make quick diagnosis. I really don't have a knee-jerk response to this, but we'll see with the next aliquot. But I'm kind of wanting to build on top of the thought process that you nicely visualized for all the listeners. Deborah, on to the next aliquot.
Great discussion. So the patient was positive for loose stools and difficult on gain weight. He reported no melena, no hematochezia, hematemesis, fevers, no change on urination, chest pain, or difficult breathing. He had non-past medical, I'm just waiting for the scribe. No past medical history and no medication. The mom has pulmonary fibrosis. And for the social history, the patient drink 5 or 6 beers per day. And if he's feeling stressed, he can drink more. And he smoked 1 pack of cigarette per day. And used 2 grams of heroin intravenously per day for the last 5 years. And he reported that this I don't know this word, binge drinking episodes often trigger an episode of the abdominal pain. Do you want the...
I think let's stop here for a couple of seconds. What's really interesting, what Leah had alluded to was maybe a background of this patient. How can we further explore epigastric pain, nausea, vomiting within a context? In the context now here, you've given us this binge drinking and then the substance use disorder with heroin. So is this enough to pivot to a diagnosis? When you mentioned this, I think everybody's antennas went up and they're like thinking, oh, okay, now the game is afoot. There has to be something related to this. So a number of things that will come to mind using more intuitive, more system one sort of thinking would be alcoholic pancreatitis. That could be one. Alcoholic hepatitis, unlikely to cause this degree of epigastric pain. I would wonder unless you have devastatingly severe hepatomegaly. And you can have alcohol ketoacidosis. That's actually, I was putting together a simulation I'm doing this afternoon, and it happens to be alcoholic ketoacidosis. So that may be a manifestation. But with that, I would anticipate the patient having more respiratory disorders due to the degree of acidosis. Remember, acidosis will cause dyspnea, and we're not seeing that with this patient. So with alcoholism, anything else that comes to mind, maybe alcoholic gastritis, that could cause nausea, vomiting as well. It could be very painful as well. But then now tackling the heroin is, I think this can cause a number of sympathetic issues. Heroin withdrawal could cause actually nausea, vomiting, abdominal pain. So you also have to think about, right, toxins. You have toxin on, toxin off phenomena, right? I went through a couple of the toxin on phenomena with alcoholism. How about toxin off? So namely withdrawal phenomena. So alcohol withdrawal can cause actually abdominal pain, maybe nausea, vomiting, but you have other coexisting findings like diaphoresis, hypertension, and sympathetic overstimulation. Then heroin withdrawal can cause the diarrhea now that Deborah's mentioned, nausea, vomiting, yawning, diaphoresis, and so on. So I wonder if we can actually put a lot of the thought on this, I guess, or maybe make a quick diagnosis based on this. But I'm going to have to be careful that this may be a detractor. But definitely, there's something you have to entertain as a possible contributor to the patient's presentation. What do you think, Leah?
Yeah, I loved your discussion, and also I think most of us, we had this type 1 thinking when we saw this confirmation of, hey, there's significant alcohol consumption, and it does correlate with these episodes of epigastric pain. So I think so far this is the most likely explanation. And I think I would first check, okay, what do you need in order to make the diagnosis of, in this case, what I would assume be an acute pancreatitis. And from what I've learned there, you need 2 out of 3 criteria. So one would be the clinical picture with this severe pain and epigastric. So this would already kind of fit. Then you would need amylase or lipase that are above, I think, 3 times upper limit of normal. And the third point would be imaging. So if you have 2 out of 3, I think those are the diagnostic criteria for acute pancreatitis. So I would want to get labs and imaging to check for that. But I think what you mentioned is really important. Just because we have that, I would then say, if the diagnosis is confirmed, does that explain everything we have? And might there still be something more if something comes up in the labs, for example, or imaging that is not explained by acute pancreatitis? So maybe there's more. And I just wanted to mention one thing, which I thought was so cool that someone in the chat mentioned it, that before, when we only had the chief complaint and a bit of the HPI, always I think that abdominal pain in itself can also be pain that might first manifest in, or that might be, for example, a cardiac cause or something from the thorax. But then later on, we saw, okay, no dyspnea, no chest pain, so it becomes less likely. But I thought it was just a great reminder that we shouldn't anchor only on abdominal organs. Yeah, concerning heroin, I don't really know much about effects and diseases associated with that, so I cannot say much about it. But now interested to find out whether our type 1 thinking got confirmed and whether we can stop there or whether there's more then to discuss.
Well, yeah, you're so methodical in your thinking and your ability to visualize your thinking. I'm just amazed at how well you've progressed over the past few years that you've been on CPS, and your level of just clinical reasoning is amazing. And I absolutely agree with everything that you've said. And I just want to just mention one thing, just if you do come across a patient like this, while you're getting the history, seeing that the patient does have a potential withdrawal, you have to switch from clinical reasoning, go off on a little tangent of management reasoning, and do identify the patient potentially having alcohol withdrawal and also hemorrhage withdrawal. So addressing those in your plan for this patient, because a number of times these patients, we don't identify that, and the patients go through terrible pains of withdrawal, and they can end up leaving against medical advice, something where if their needs are not met and they feel worse, they will leave or sign out against medical advice and leave the institution, and that could end up causing devastating progression of disease. So as part of the, Yusuf's not here, but Yusuf has a great interest in management reasoning, and just want to make a plug for any patient that you have with potential for withdrawal. Back to you, Deborah.
Great discussion. So going for the physical exam, the patient was after had like a blood pressure of 158 with 158 and 88, a heart rate of 103, a BMI, the rest was normal. A BMI the patient had like of 23. The patient was like anxious, but besides that was looking normal. And let me see. The heart was normal, regular heart rate, no murmurs. The lung too clear to auscultation or crackles. No wheezing, and the abdominal was soft, tender to palpation in the epigastric region without rebound, no palpable mass, no hepatosplenomegaly. And everything was normal, orientated. The patient had no edema. I can give like some labs. Actually, everything was normal, like CBC, CMP, all that was normal. And I can stop here.
Okay, great, Deborah. I'll ask Leah since the exam. I guess we'll start with the vital signs. What do these vital signs clue you in on, Leah?
Yeah, so I think my reflex thought was this patient must be in pain. So that was just the first thought I had, because there's this elevated, so he's tachycardic, so heart rate is elevated, and then blood pressure is also more on the higher side. And other than that, so I think that's the main conclusion I would draw. I can't say really much more, but if this patient is in pain, then I guess that would be explained by this also maybe some sympathetic activation because of that. And then the tender to palpation in the epigastric region is kind of not new information, but just confirms that maybe that might be more the localization. And then obviously I also listened into no palpable mass, but we have to also know that our examination is not perfect. So I think imaging will always be necessary to be able to rule out hepatomegaly or splenomegaly, for example. Yeah, I don't know. Is there more information that you would draw out of this, Ravi, or what would be the thought processes you would continue?
I think my thought process would be, I was very interested to see what you thought, and you absolutely honed in on the sympathetic response, and you just beautifully just went through that this could be pain, but you didn't neglect that this could also be part of the withdrawal process as well. So this could be giving us early insight into the patient potentially developing withdrawal, which could be either from alcohol or heroin. The tachycardia, namely the hypertensive, the hypersympathetic response that you had mentioned, and the physical exam just being tender in the epigastric region, it absolutely does support all the hypotheses that you had generated initially that are located in the epigastric or anatomical region. So I think something is developing in that area without any palpable mass, so you can't palpate maybe a tumor, maybe a vessel, maybe like an aneurysm, maybe a gastric distension. So we're not able to really feel anything, but pain is definitely there. I think also you have to, I don't think it's that's happening in this case, but there is a maneuver called Carnot sign where you would perform an exam to determine if there's anterior cutaneous nerve entrapment, and that will be performed with having the patient lie still, and you palpate both superficial and deep. Would be painful, but then have the patient bear down or bring their flex their neck, tightening the anterior abdominal wall musculature. And if there is pain, then that's likely the anterior abdominal wall, maybe due to anterior cutaneous nerve entrapment syndrome. So it's sort of like when you palpate the chest wall and you have costochondritis or Tietze syndrome, something like that, superficial chest wall pain. So you can also have a complex of superficial abdominal wall pain. But here I think there's definitely something more sinister that's unfolding in front of us, and I'm quite not sure. But Leah, what do you think? You generated, I think one of the most earliest hypothesis was pancreatitis, and we need to further refine this. What would you order next?
Yeah, I think lipase and amylase would be very helpful in the labs also to find out more. It's great. Many people in the chat, I think, also mentioned that. And then there was one thought that kind of popped up in my head, and I'm not sure how relevant it is here, but as I was thinking of GI and alcohol associated diseases. I thought of GI beriberi as well, which I think can present with abdominal pain. And I think it's probably base rate not as likely as acute pancreatitis, and also with this remitting kind of symptoms. But I just wanted to mention it as a differential because I thought when I learned about it first, very interesting, because thiamine deficiency, there are many diseases associated with that. And I often got confused, okay, because there's Wernicke encephalopathy, which is more the acuter confusion, ophthalmoplegia, ataxia presentation, which can then go on into a chronic irreversible, which is, I think, Korsakoff disease. And then you have also the wet and dry beriberi that you might have heard of, which is more the cardiac manifestation. And then there's this GI beriberi version as well, but they're all diseases that are caused by thiamine deficiency, which is associated with alcohol abuse because of the lack of the nutrients or the malnutrition also associated with that, I believe. So I just wanted to throw that in there because I think that was very interesting when I heard about that the first time.
Well,
Yeah.
incredibly, I didn't know about that. You did amazing job waxing lyrical about thiamine deficiency, but we always think about those complications that you just mentioned there. But the GI complication I wasn't aware of, so something definitely to think about, and I'm going to explore later on when I reflect over this case. So I think, yeah, getting back to, I do want to mention a couple of people mentioning in the chat. Yeah, could this be, in fact, you would also mention this undulating sort of waxing and waning abdominal pain over a certain amount of time. Could this be a chronic pancreatitis where you do have pancreatic exocrine insufficiency? I think Mario had mentioned, and the diarrhea could be from that. So kudos to Mario to put that in the chat. And then just walking back, you had mentioned there's some people talking about angina, and we do have to respect above the belt. Take a look, or sorry, above the diaphragm. Take a look at two causes of epigastric pain, which is ACS, and also pneumonia can also radiate to the epigastrium. So early on in the process, I would have actually put those things I forgot to mention. And what will be a cause of ACS? Well, I have dealt with a number of cases where heroin can be packaged with fentanyl, cocaine, and cocaine can cause vasospasm, is also a prothrombotic agent, also increases the sympathetic response. So it's a four-pronged approach to developing ACS in a young patient. So something to think about as well. Back to you, Deborah.
So a little bit of more labs. So the lipase was normal. The triglycerides was normal. HIV was asked and was negative. Hepatitis C, -2. Hepatitis B was negative. Shema, someone asked in the chat for a urinary analysis that was everything normal. And we have some imaging that will reveal the diagnosis.
Wow. Okay, so this is really interesting, and I think I'm not really sure where to go from here, because so AST, ALT is normal. Basically, we have lots of normals, which, okay, it helps us maybe to make some things less likely. It's nice to see that the triglycerides, for example, are normal, because that they can also be one cause of acute pancreatitis, for example. And then always in people with IV drug use, check risk factors, or they are at risk. So you check hepatitis C, hepatitis B, HIV. So it's good. I think it's good workup that was also checked. And now that the lipase being normal, I wonder if it's too early in the course maybe for it to be high yet. And that's why maybe it could still be acute pancreatitis, but the lipase is not just high enough yet. And I'm curious then to see, Ravi, what your take is on it. I have so far only come across a case where it was normal, but that was because it was too long ago. So that's why it had normalized already. Which in this case, I guess we don't have exact the time frame when the pain started or ended, when this presentation was, or when the labs were taken. But I guess if the imaging is still confirming pancreatitis, we could make the diagnosis just because of the clinical picture. So I think I would still not take it off my differential. But yeah, to be honest, this negative lipase did surprise me, and I'm still unsure what to make of this. Ravi, what do you think?
I think, Leah, you just exhibited high-level thinking in that you didn't immediately take off the table the differential of pancreatitis. I think everything you absolutely mentioned, I think it's relevant that maybe maybe with chronic pancreatitis, the lipase may not be devastatingly elevated. We always learn with acute pancreatitis that the lipase does elevate. It usually will increase later and last longer. So we usually look for amylase will rise initially. So I think at this point, I wouldn't definitely take it off the table. And I think imaging, like you mentioned, is key. In the image will show us if there's hallmarks possibly of chronic pancreatitis. Also, the image may actually reveal something else that could be actually bubbling under the surface and causing something like this. So at this point, I really can't, I don't have a hypothesis to validate. Now, we've gone through this sequence of hypothesis generation in the first few aliquots, then hypothesis refinement. We took the initial few diagnoses we had and possibly started thinking or concentrating more on pancreatitis, and now to validate it, you did all or asked for the testing that was necessary. So amylase, lipase, and now also imaging. So that will help us validate it, although the chemistries didn't help validate our number one thought, but hopefully the CT will help us narrow down this diagnosis. Deborah, back to you.
Great discussion. So it was done a CT of the abdomen that reviewed the diagnosis. Just give me 1 second. Please don't kill me. Oh. Wait, some technical problem, friends.
Maybe in the meantime, I can just tell about some comments in the chat, which I thought were really interesting. Ibrahim mentioned that people with chronic pancreatitis tend to, even if it's severely painful, only be associated with minimal rise or elevations of amylase and lipase. So perhaps because of this long-standing history, it might already be more of a chronic process where this might be relevant. So I thought that was great information. And also Ashutosh also mentioned that gave information on how fast amylase and lipase are rising. And amylase tends to rise between 6 and 12 hours, and lipase between 4 and 8. And then also have different ranges for the days, how high they remain, or how long they remain high. So I think it's always nice to learn and know about these ranges. So yeah, Deborah.
Yeah, sorry. So the CT of the abdomen shows atrophy of the neck and the body of the pancreas with extensive calcification, particularly in the toe. The main pancreatic duct was dilated and no peripancreatic fat stranding, and the patient was diagnosed with chronic pancreatitis. And I had like some few things that I was learning about, like normally we think about pancreatitis with the alcohol, but this patient had the nicotine and the heroin use, so all that can make the more chance for the patient have. And the CT, the changes on the CT on the pancreas take some time to show up, and a lot of patients can be diagnosed with pancreatitis that is recurrent, that happens often. And the treatment in this patient, it has to be the alcohol sensation and the cigarette sensation, and they are both important at the same level. So one something that I didn't know, sometimes we talk a lot of alcohol, but in this case, we have more risk of factors for this. So great discussion, Leah and Ravi. Thank you so much.
Wow, Deborah, that's an absolutely stellar explanation of the findings of the CT and as well as the pattern of labs there. So that was interesting. I know somebody mentioned New World, but studying for steps that actually lays a foundation down, or the clinical years in medical school lays the foundation down for learning disease processes. And pancreatitis, we always learn as retroperitoneal sort of pain in the back, or a band, a belt-like pattern of pain, but here it's just abdominal pain. I've seen many patients not follow the textbook, so that would have been may have helped us early on in the process to narrow down a differential to pancreatitis. And although I think I have to look at chronic pancreatitis doesn't follow the routine or usual pattern of abdominal pain. So really I'm appreciative of you, Deborah, for presenting this great case of something that we do see, and I'm very disturbed to see this in a very young person. So we always think about chronic pancreatitis in patients maybe drinking for years and years and years. And I didn't also know that the coexisting of heroin use can also actually add to the risk factors for developing chronic pancreatitis. Any reflections, Leah?
Yeah, first of all, thank you, Deborah, for presenting. This point of dealing with several risk factors and paying attention to them as well in the treatment had never occurred to me like that. So I think that's definitely something I want to keep in mind. And I think it was just such a good case also to discuss and to think through, because I think it's a common and important thing to know about and to manage. So I thought that was a great case also to kind of get all the wisdom in the chat and the questions. And I want to thank everyone who was participating also with the chat. I think we could learn so much from just the different thoughts and comments that were there. So if it's a question, if it's a comment, thank you for participating today, and also for just listening in and sharing this space.
I think Hui is going to take us home with the teaching points.
Hi, everyone. Thank you, Dr. Ravi. Thank you, Leah, for this amazing discussion. Thank you, Deborah, for stepping in and give us this amazing case presentation. So, yeah, there's a lot of information, and thank you everyone for participating. And here are some teaching points for you. So, we started with this patient with the chief complaint of abdominal pain. So the first thing we talk about when we try to approach abdominal pain, we think about anatomical. So we think about the organs were located in each of the quadrant, in this case, epigastric location. So, and sometimes it can be tricky because sometimes the abdominal pain is not localized, but diffuse. So in this case, for a young patient, we have to consider the past medical history, risk factor, behavior, which is in this case was very important, the social history, and ask if this is a recurrent episode, if there's any trigger, and if the pain returns to baseline or becomes more severe every time. And of course, when we think about a severe pain and the location being in epigastric, the first thing we think about is pancreatitis. That's the first thing. And there's a great mnemonic for pancreatitis, which is I get smashed. And of course, we have to think about when it comes to abdominal pain, other organs such as spleen or even the stomach, and also think about that abdominal pain can be caused by an obstruction versus ingestion. So in the case of obstruction, that would be a stone. And in case of ingestion, alcohol, toxin, or vascular causes. And when we think about abdominal pain, we have to think of the itis. Like Dr. Ravi said, we have to think about cholangitis, hepatitis, pancreatitis, and determine if this is surgical emergency. And if we see the abdomen, if we see the massive abdomen distended, we think about an obstruction, and that obstruction also can be a mass or product of malignancy. And we have to be very aware also with the vital signs, because this way we can determine what is the severity of this presentation. We also consider when it comes to abdominal pain, sometimes it's not just the abdomen, it's not just the organs within the abdomen. We also think about other causes like cardiovascular. So we think about causes acute coronary syndrome that can induce by the use of opioid, and that can induce vasospasm. And we also think about superior mesenteric artery syndrome. Other causes, yes, there's a more broad way to think about abdominal pain. And we also have to take into consideration in patient with a substance abuse disorder that he actually is experiencing withdrawal syndrome. And Dr. Ravi taught the existence of the Carnet sign. So if it's possible, positive this maneuver, that means that there's an anterior cutaneous nerve entrapment syndrome. And also we talk about lab, and we have the amylase. For example, it says that it rises within the 6 to 12 hours and remains high for 3 to 5 days, and lipase as well, and that will rise within the 4 to 8 hours and remain high for 8 and 14 days. And for in case the pancreatitis, Aliyah talked about how we do the diagnosis. We take in consideration the clinical presentation of the patient, the increase of amylase or lipase, but in this case they were normal, but having lab that is normal doesn't exclude the diagnosis of pancreatitis. And also a positive imaging. These are the three main things that we take into consideration when we do the diagnosis for pancreatitis. And also it is important to remember that the chronic pancreatitis may not follow the usual pattern of the acute presentation. And in this patient, we also talk about the alcohol-induced abdominal pain, which is, we can think about different differential diagnosis, which is alcoholic pancreatitis, alcoholic ketoacidosis. But in this case, if it's ketoacidosis, it will present with dyspnea, and also alcoholic gastritis. And Leah also mentioned deficiency, vitamin deficiency, which is very important to think about in a patient who is a chronic alcoholic. So she mentioned thiamine deficiency, which is B1. Vitamin B deficiency, we have wet beriberi, is more cardiac, and we have the Wernicke encephalopathy, and also other vitamins that can be deficient can be folate, vitamin A, and vitamin B6. And another thing about the approach in this discussion is the approach to nausea and vomiting. Even though this is like non-specific symptoms, it can be presented, for example, in DKA, it can present with the symptom, or in the case of this patient, we have the hearing withdrawal syndrome, which is present with yawning, tachycardia, nausea, vomiting, diarrhea, and also abdominal pain. So yeah, these are my teaching points. Thank you everyone for participating, and I hope all of you have a good evening, good afternoon.
Thank you, Hui. Such so well delivered the teaching points. I felt like I was listening to a lecture. So just such a expertly presented teaching points. Really, and you captured like almost every one of the points that Leah had so nicely put out there. So I appreciate you for doing that. Thank you, Noah, for also scribing. Take care, everybody. Have a good rest of your Tuesday, and see you back here tomorrow. Bye.
Mm-hmm.